All right. Well, hello, everyone. Thank you all for being here. I'd like to introduce our guest speaker for the session, Dr. Rosemary Batt. Dr. Batt received her BA at Cornell and her PhD at the Sloan School of Management at MIT. She previously coordinated the Global Call Center Project and is currently the Alice Hanson Cook Professor of Women in Work at the ILR School at Cornell University. She has published over 100 books, book chapters, and articles. She is co author of the book Private Equity at Work with Eileen Applebaum, and her work has appeared in journals including the Academy of Management Journal, Industrial and Labor Relations Review, and many more. Her work specializes in management and employment relations in industries such as healthcare, and she is here with us virtually today to talk about private equity capital in the healthcare sector. So I'd just like to say thank you, Dr. Bott, for taking the time to speak with us today. So please join me in welcoming her in today.
So thank you, Stephen, and thanks all for inviting me. I'm very happy to be presenting to you. I think it's really important for students in healthcare, medical professions, and many others to really understand the ways in which financial actors are moving into Main Street companies, and particularly in healthcare. And so I've been working on private equity since about 2010. And after the general book that we wrote, we started looking specifically at healthcare. So my co-author and I, Eileen Applebaum, we've been looking at these issues in healthcare for about 10 years, and we've done many working papers that I would be glad to share with you. They are located, just for your information, on the Center for Economic and Policy Research website. So that is called CEPR, CEPR, and you can Google our work because we have done a series of working papers on private equity in many different healthcare segments, including hospitals, nursing homes, home health, hospice, mental health, autism services, and others. So I'm going to focus on just a couple of those segments today. But what I really want to do is give you a clear idea of what the private equity business model is. And then I want you to stop me at any time. I want to be as clear as possible, and this is a bit complicated, so you shouldn't hesitate in saying, wait a minute, I don't understand that. Can you repeat it? That's all fine. I also want to say that private equity is just one actor in a larger phenomenon that we call the financialization of healthcare. And by that, we mean the increased role of financial actors, investors, Wall Street actors, private equity, hedge funds, venture capital, but also a larger body of investors who are moving in, taking over healthcare organizations in order to extract wealth and imposing a financial logic in healthcare rather than a mission-driven care objective. And we see this in many areas, but we focus on private equity because private equity firms have been the actors that most created the financial model and have made it legitimate for a range of other people who say, well, if private equity can get away with it, why can't we? And so the private equity firms really began getting into healthcare in the early 2000s, but it was mainly in hospitals and nursing homes. And then since about in the 2010s and now, they've moved into many other segments. So outpatient care, many physician specialties, anesthesiology, radiology, dermatology, and then into areas clearly more recently, mental health, hospice, home health, which they call hot markets. So just the terminology of saying, I'm going to make money over people dying of opioid addiction, or people who have mental health problems, or people who are in hospice who are dying. And this is a hot market to make money, shows you the kind of financial logic, the financial drivers in the activities of these people who, and I want to be clear, I'm not going to put any intentionality in our discussion. Many of these actors say, well, healthcare really needs our money. Healthcare really needs, we can be more efficient, we can provide higher quality and more efficient services through our financial activities. So there is a whole debate going on around whether private equity and other financial actors can help healthcare. I'm going to take a more critical view, and it's not meant to say that all private equity actors operate this way. What I'm going to show you is the kind of financial strategies that are used that are perfectly legal. And how there are many negative outcomes that have come as a result of behavior that is financially driven. So that is of great concern. And it is not to say that all private equity actors or all investors act this way, but that because these activities are legal, it creates an environment in which many more people can engage in financial strategies that, whether intentionally or not, may have very negative outcomes for patients and for physicians and healthcare professionals. So that's what we're going to look at today. But I want to be clear, I'm not saying this is a good guys, bad guys argument. I'm saying this is what the system allows and why I believe it has many activities have proliferated because they are legal and people have pursued them. So with that kind of introduction, let me also say, I've been at Cornell since 1995. I've worked with my co-author, Eileen Applebaum, for many of those years, and all of our work in private equity and healthcare is jointly conducted. So with that, I'm going to put on my slides, and I'm going to go through the private equity business model. Then I'm going to provide you with a couple of key examples that are occurring right now. And then we can ask questions at any time and go from there. So. Okay, so is that clear for everyone?
Yes.
And I want to also make sure that it moves. Sometimes I have trouble with the slides moving. So let me just see. Can you all see that slide move to a new slide? Okay, what I'm going to give you is two examples of empirical evidence around the negative effects of private equity investment in healthcare. And the first is a nursing home study that was conducted by Atul Gupta and colleagues when he was at the University of Chicago. Now he's at Wharton Business School. These are very straight economists who use highly rigorous methodologies. And this is considered the kind of gold standard in econometric studies of nursing home and private equity investment. They compared private equity owned to for-profit nursing homes, and also compared the nursing homes that were for-profit that were transferred into private equity ownership. So a before-after comparison that provides quite rigorous standards. They looked at nursing homes between 2000 and 2017, 15,000 a year and tracked when they moved from for-profit enterprise to private equity enterprise. What they found is that mortality rates in private equity owned homes were 10% higher than the overall average for the for-profits, but Medicare billing was 11% higher. So both there are worse mortality outcomes, but also higher prices for the Medicare trust fund. The frontline nurses spent fewer hours with patients, and to compensate, the homes made 50% greater use of antipsychotic drugs. And these are associated with greater mortality rates. So in all, there were about 21,000 people who died prematurely in the 12 years due to private equity ownership and the ways in which they cut staffing and used practice medicine techniques to cut costs. So that's one major study that's received a lot of attention and has led to congressional hearings and concern over private equity involvement in healthcare. The second study is a
Dr. Batt?
Yes.
Yeah, my name's Chris. I just had a quick question on that. What is the distinction, like in simple terms, I guess, between a for-profit that's not equity owned, right? I mean, aren't they all profit motivated?
That's a great question. You know, if I have a slide on that. So these two cases were just kind of teasers, but there are big differences. And right after I show you these examples, I'm going to move into the private equity business model and explain how it's different from the for-profit.
Thank you very much.
Yeah, so sorry that I'm keeping you waiting for another minute. But let me tell you about Steward Healthcare. How many of you have heard of Steward? Okay, Steward has been in the news, all over the news, in fact, if you're looking for it. It is a system that was based in Massachusetts, and in 2010, a private equity firm named Cerberus Capital bought out a 6-hospital Caritas Christi chain, a Catholic chain, for $247 million plus debt financing, and renamed it Steward Healthcare. So it was all Boston based. They bought a couple of more hospitals. And then in 2021, Cerberus Capital sold Steward Healthcare and made $800 million in profit. Steward CEO by that time owned 2 yachts, one valued at $40 million and located in the Galapagos Islands. And Steward Healthcare was $9 billion in debt, owed $50 million in back rent, $600 million to creditors, and filed for bankruptcy. And all of the financial actions were legal. So the question is, how did this happen? So this is the very new, it just went bankrupt in May of this year, so just a month ago. And I'm going to go into detail on this case. So now let's go to the private equity business model and explain how this works. So here's the business model. Now I want you to recognize that the private equity firm and the general partners are here. So there's a private equity firm and partners, and what they make money by setting up a private equity fund, and the GPs, the general partners, put in less than 2% of the money, and they get the rest of it by raising it from institutional investors, pension funds, wealthy individuals, and 98% of the capital comes from that. I should say 35%, almost 35%, comes from pension funds. So these we consider to be workers' capital. And that money is being poured into private equity in order to make higher returns than they would get from the stock market. The private equity fund then buys out a company. In this case, it would be a healthcare organization. They use about 30 or 40% equity, and they borrow the rest, 60 to 70% debt, which is put on the portfolio company. So this is like if you bought a house and had a mortgage, but you didn't actually have to be responsible for the mortgage because the mortgage, the debt is put on the company. Then in addition, they do another portfolio company because in using only 30% of their equity for any buyout, they can spread it over more companies. And then they get advisory fees and management fees. So they charge the limited partners 2% annually for managing. The limited partners have to keep their money in for 10 years. And they commit it and they can't use it for other purposes. And the private equity firm or fund takes complete control over making decisions on how that money will be used to buy out these companies. So the limited partners have no control. The private equity fund then also usually takes advisory fees or monitoring fees from the portfolio company that go directly to the private equity firm. So for example, if there's a merger or acquisition, the private equity firm immediately gets 1% of that deal. So there's an incentive to do additional financial transactions because for every financial transaction, the private equity firm will get an additional 1%. So then they need to return the money to their investors in a relatively short period, we'd say 5 years, because they want to start another fund. They want to start building up another fund, a follow-on fund to fund number one. So if they have not given their returns back to their investors, the investors will say, well, why should we, up for another fund if we haven't seen these returns? The limited partners want to buy into the private equity firm fund because they promise outsized returns that will beat the stock market. They promise that they will beat it by about three percentage points. And that is because the limited partners are keeping their money in for 10 years or, a long period of time, keeping that money wrapped up. Okay, now it's about year 5 and what happens, well, the private equity firm has to sell the company and it has to return money to the creditors and then to its returns to its investors. The private equity firm gets 20% of the profits off the top. So despite the fact that they have put in less than 2%, and if you multiply 2% times 30%, what do you get? 0.06%. So despite the fact that in any one buyout, the private equity firm puts in less than 1% of the equity, they get 20% of the returns. This is an asymmetric relationship, and this deal structure has been in place since the leverage buyouts first started in the 1980s. And one might say, well, why hasn't it changed? Why don't the investors want more? And the response is that this is a kind of an institutional arrangement that was established in the 80s that people bought into because there was a lot of money going around at that time. And it's kind of been locked in as a legacy or practice, common practice. And it's very difficult to change at this point because any one limited partner has relatively little power vis-a-vis a large private equity firm. So we can talk more about that, but that is the deal model that has been in existence this time. So once that occurs, then the private equity firm does the same thing again. And so what we need to understand is that a private equity firm has a number of funds. The funds have a number of companies they bought out. They completely own and make decisions regarding those companies. They are not traded on the stock market. They are private. And the private equity firm is maximizing profits at the level of the firm, not at the level of any given organization. And given that they have many companies, if any one company goes bad or goes bankrupt, and they only have 1% of their own equity in that deal, the private equity firm will not be negatively affected much. The stakeholders will be the portfolio company or the healthcare organization will be, the limited partners may be, the creditors will be, but not the private equity firm. So this is what we call, we actually refer to this as moral hazard in economics, that the private equity firm is winning on the upside, but has very little downside risk because it's playing with other people's money. That's the kind of classic buyout model. Now let me go a little bit further. And then here's an example. So Blackstone owns 479 companies. KKR, 466. Carlyle, 180. TPG, 280. And together, private equity firms own 32,000 companies and employ about 12 million people. So these, particularly the large, there are small private equity firms that have a somewhat different model, but most of the capital is in the larger firms. And because they basically operate as conglomerates in which there are so many companies under their purview, that if any one does not do very well, it's not going to really affect the finances of the firm itself. Okay. Now, let me stop there a minute and just see if there are any questions on that private equity firm business model. And then I'm going to move to the portfolio company and go down more deeply.
Oh, I'm so sorry.
Go ahead.
I did have a question actually on the last slide. Because there was a handful of numbers on here, like the 2% management fees a year, GPs get 20% profits at sale. Are those like hardly set to that 20% or 2% a year, or is that something that where there's like wiggle room where like some private equity firms will have general partners get 18% or like they can negotiate? Is there anything like setting it to those numbers?
Yeah, that's a great question. So the deal arrangements are in the legal document that is called a limited partner agreement. And those limited partner agreements are completely private. There is no public information. And private equity firms have threatened to stop doing business with any, say, pension fund that reveals the details of the limited partner agreement. Having said that, the 20%, so this is called the 2 and 20 model, is pretty standard. Now, the large, very large pension funds, say the California pension fund, they may be able to wiggle a little bit. They may be able to say, well, we're going to only do 1.8% management fees. Or they may try to, after 5 years, they may say, okay, the remaining money, we don't even know if you're going to invest it. So we want to get a reduction on our management fees. So there's some negotiation that can go on. And it's mainly, though, the very large investors who are able to do that, particularly the large institutional investors. Does that make sense? Does that answer your question?
Yes, thank you.
Okay.
I also have a question on this slide. What is the incentive for the banks to loan money, given that the private equity firm doesn't have much stake in the game? You would think they would have some concern about bankruptcy and being liable.
they get great fees. So the bank, the investment banks, and the creditors, they make money by a kind of constant churn of deals. So they want to make deals and then they loan the money and then they get a return. They're getting a return. I'll show you on the next slide. They may often have a high interest rate because there's so much debt put on the company. And so they are getting a constant return through the interest rates they charge. Now, the interest rates have been low, but they get a fair amount because of the amount of debt that is often loaded on the portfolio company, which means that the interest rates are higher. They're not, A grade, they may be B or C grade rates. And I'll give you an example of that later on. But the banks, and they also, the investment banks and the large private equity firms in New York, they've been doing business together since the 80s. Now, this model is what we call leverage buyout model, and that was kind of innovated it was actually 1978 when the Kohlberg, Kravitz, and Roberts, KKR, bought out Hudai Corporation, and then we had a decade of leverage buyouts that kind of ended in disaster with the junk bond scandals and everything else. So there was a decade when this was going on, and then it was kind of peeled back when there were a number of scandals. But the elements of this model then re-emerged. They still went on in the 90s, but they particularly re-emerged in the 2000s, in the bubble years of the 2000s, when there was a lot of exuberance, where the stock market was doing well, etc. And this is when this model took off. And it took off. It was very slow in healthcare in the 2000s, and it was really since 2010 that's particularly taken off in healthcare. Okay, let me go on. Now, this is at the company level. So the private equity firm has bought a healthcare organization. And what is the strategy? Well, they do a lot of due diligence to figure out how are they going to exit. So before they even buy something out, they've figured out what their strategy is for making money and getting out. So they start with a level of debt that the company can sustain. So if it's a large organization, it can sustain more debt. There's more collateral. If it's a smaller organization, not so much. Then that capital structure drives the strategy. And there are two ways to make money. One is through operational strategies. And that's like going back to Chris's question, that's like any other for-profit company or nonprofit, is that you want to do operational strategies that will be efficient and effective and provide quality. So it may be in introducing new technologies or workforce training or other things you want to do to maybe marketing to improve your operations. The other is what we call financial engineering strategies. Now, this exists where the private equity firms can't make enough money via the operational strategies, and they look for financial strategies. And I'm going to go through what I mean by those in a minute. And then the outcomes are cash flow and to exit in about a 5-year period. I want to be clear. It's cash flow so that they can service the debt, right? And it's not, you don't necessarily want to maximize profit, like profit margins, at the level of the company, because the private equity firm wants to maximize profit at the level of the firm itself, not in a given company. It wants to maximize cash flow to keep paying the service on the debt and extract cash. over 50% of private equity capital is invested in large buyouts that rely primarily on the financial engineering strategies. So that is the key. When you have small boutique private equity firms and they're engaged in smaller buyouts, you tend to find they're able to, for example, introduce marketing innovation or accounting or human resource management systems that the small company has not been able to do. The small, maybe a small physician's office. But the larger organizations have already done a lot of that. And so that's not how a lot of money can be made. So it depends on the size of the buyout and what the resources or what the stage of development is of the given healthcare organization that is being bought out. And so I'll give you more examples. Okay, so here's the financial engineering story. First of all, if you use excessive debt to buy out a provider, you load the debt on the provider, and that reduces taxes. It reduces bankruptcy. It increases bankruptcy risk. It forces cost cutting to service the debt and short staffing and supplies. So imagine a manager of an organization that has a debt load of like, I'm just going to say 50% of its value. Well, then there's a constant pressure for that manager to focus on cost cutting to increase the margins, right? As opposed to someone who doesn't have that debt load. And that goes to Chris's question about why there's one difference between the private equity owned and the for-profits. The for-profits usually don't have that level of debt. And so they don't have to service that debt. They're not squeezed as much in terms of their spending or how they have to think about costs. The second is they have these excessive portfolio company fees I mentioned, where you have a transaction or an advisory fee that you're charging to the portfolio company, regardless of whether, and again, I should use healthcare organization here, regardless of what you're actually doing. By the way, there is no accounting for the management fees and the advisory fees that the firm receives. In other words, there's no transparency. The limited partners never see an expense form of how their management fees are being used. They can use them however they want. No transparency. And that's because there's no law that requires it. The Securities and Exchange Commission obviously requires these things of publicly traded corporations. And this is again how they're different. But in a private equity owned operation, the private equity firm takes that private if it's not already private. And the law, which was modified under Dodd-Frank, makes private equity firms submit a few minor, like fairly superficial financial reports to the SEC, but they're not allowed to be made public. So whereas publicly traded corporations have to submit these forms that are available for public purview, private equity firms do not. So there's very lax regulation and transparency with respect to these firms. Dividend recapitalizations, this is a fancy word, and all it means is that, say I'm a private equity firm, Blackstone, I've owned a healthcare provider for 4 years, and I don't see how I can sell it, but I need to give returns back to my investors. They're waiting. So what I do is I take out a loan and I put it on the more loans or more debt on the company I own, on the healthcare provider. And I use that loan to pay dividends to myself and my investors. Now, normally people will take out a loan in order to do an investment. I maybe need to invest in new technology. I want to improve my operations. These are loans exclusively used to pay dividends. And the debt load is put on the portfolio organization. And that means that then their bonds, the healthcare organization, for example, their rating for the rating agencies goes down. And now that we're looking at them paying interest rates on what may be junk bonds, because they have so much debt on their organization. A couple more things. There's something called a sale leaseback that I'll explain. I'll go into detail later on. But basically, the private equity firm splits the company, the provider. This has happened a lot in nursing homes and more recently in hospitals. I split the nursing home into an operating company, that is the operations of the nursing staff and the and how we take care of people, from the property, the buildings, the real estate, etc. And I take the property company and I sell it to a real estate entity. And I use the proceeds to pay myself a dividend. I don't use the proceeds. Now, some companies will sell their property in order to expand their operations. Private equity firms do not use it in that way. They do a sale leaseback in order to give themselves dividends as another way of extracting wealth when they can't get it through selling. The provider organization, the nursing home, then is saddled with long-term inflated rents and annual escalators on property they used to own. And I'm going to come back to this because that immediately puts their net revenues lower by definition. And it's a question then of whether Medicare and Medicaid in healthcare can keep up if they're paying rent and that's constantly increasing. Because when they owned their own property, they weren't paying rent, right? Okay, another strategy is monopoly power, which is private equity firms look at places or organizations where if they take control and then they add on they buy out other providers, they may be able to achieve strong market power or monopoly power in a given local market. So you buy other providers and you create a chain that may have local, regional power. And because the buyouts in healthcare are small, they may be 50 million, maybe 100. The buyouts go underneath what is called the threshold for the federal government to actually investigate. It's called the Hart-Scott-Rodino threshold. So if my buyout is underneath that threshold, the federal government won't even look at it. But in the meantime, if I've done 10 of these buyouts or 15, now my chain may be worth 2 billion or 1 billion, whatever it is. So it's a way of skirting antitrust regulation or oversight by these buy-ups that kind of get rolled into one platform. And we'll see this it happened in nursing homes. We're going to see it in the Stewart case. Private equity is responsible for 45% of the merger and acquisition activity in healthcare, even though it's a tiny percentage of the overall number of organizations. And so they're disproportionately leading the way in the consolidation of the industry. I'm going to get into now Chris's question finally, and let me go through this and then we will answer any questions and we'll pause. But this is a summary then, Chris, of how you think about it. So private equity, so if you look at the capital structure, there's 70% debt, 30% equity, maybe it's 60-40 versus the opposite in for-profit corporations. For-profit corporations have inched up overall in the economy, have inched up more to 40%. But in healthcare, we don't have data on it. We don't have good data, but it would be lower. Regulatory oversight, as I mentioned, little to none. They don't have to report much to the SEC. There's no transparency. There are no laws that require, public disclosure of the limited partner agreements. So it's very low to none, whereas here it's high. They don't have to report how much debt they're loading on a company or on a healthcare organization. Transparency, accountability, low. Risk-taking, though, is very low for the private equity firm, but very high for the company that is taken over. Whereas it's relatively low for the for-profit companies. Then one more set of comparisons. Private equity, they use asset sales for investor dividends, as I just said. For-profit corporations, that's rare. And that is because for-profit corporations want to hold on to their assets because it's a long-term investment. Private equity firms are going to flip their ownership of an organization in a 5-year period. In healthcare, on average, it's like 4.7 years, I think is the data I last looked at. So because they're going to get out, they really don't care if the assets underneath the operations stick with the operations. Whereas if you look at a corporation like Healthcare Corporation of America, which is the largest, 280,000 employees, they have never sold their property. They are not going to they are holding on to that property because it's very, very valuable. Debt used for dividends, frequent, rare. Fees paid to the healthcare enterprise, as I noted, are paid by them. There are these advisory fees, etc. Taxes, private equity pays a low capital gains tax, which I think is maybe now 20%, whereas for-profits pay the corporate income tax. And then reputational lists, that's the last thing I want to talk about because the investors, the limited partners, are keeping their money in for 10 years. They're stuck. Whereas the for-profit corporations are vulnerable to shareholder activism. Shareholders saying, wait a minute, we don't like what you're doing. And so they may sell. They can sell their stock at any time. And so the for-profits have to be more careful about their reputation and whether the shareholders are happy or not. And to give you an example, the CalPERS wanted to get out of a fund by, I think it was Steve Schwartzman, that owned the gun factory that built the guns that killed the children at Sandy Hook. This was like, we don't want any part of this. It took them 3 years to negotiate and to, all this effort to finally get the private equity firm to sell the gun factory. And so the limited partners don't have as much say, and they can't kind of threaten exit the way that a normal stockholder can. And then the other thing is, if you think about the puppeteers, how many of you, the Toys R Us disaster? How many of you know about Toys R Us? It went bankrupt, right? And how many people knew that it was due to private equity ownership? It was. And so, the hoopla was, oh, the retail apocalypse and, all the online competitors, blah, blah, blah. But it was that private equity firms owned the company and put huge amounts of debt on it and did not upgrade the merchandise and then the online systems, and it went bankrupt. But everybody does the attribution to Toys R Us. Oh, they were poorly managed. They haven't kept up. And so that's another thing that we see in the private equity examples. And I'm going to show you one that you probably, most people would not know was driven by private equity. So those are some of the differences that I see in these two ownership models. And I'm going to stop for a minute and see if you have questions. And then I'm going to go into, I want to look at a couple of these cases. So let's stop for a minute. Any questions or comments? Okay, well, I want you to, is it Subhi?
Yeah. Hi, I wasn't sure whether to ask now or wait for the end, but I'm just curious as to why a portfolio company would want to contract with a private equity firm because, there is you discuss these practices of like putting the debt on the portfolio company and, bankruptcy and things like that. What are why would they then contract with the private equity firm if like these are some of the negative outcomes?
Great question. And there are a variety of reasons. So I'll give you a few different scenarios. Some outside of healthcare, some family-owned businesses. You have a founder, and the founder has been doing it for 40 years and wants out. And so they may look for a private equity firm to take over. That owner will get a really, really nice deal. And that's that person's lifetime retirement. So private equity will pay a lot up front. That's one kind of scenario. Second is I did a big study of autism services, and in small businesses, for-profit or nonprofit. Well, nonprofits have a lot of trouble getting access to capital, but for-profits, because of this gets a little complicated, but because of the consolidation of the banking industry. So going back to the 90s, 80s and 90s, the banking industry was deregulated, which meant that, commercial banks and investment banks could merge for the first time since the Great Recession, when they were separated because of the Great Recession. So we did away with those barriers, we did away with regulation, and they started merging like crazy. And so we have mega banks now. And the large, even regional banks, mega banks, do not want to make small business loans. So there's a dearth of capital for small businesses. So in autism services, there's a great demand for services, and it's very hard for them to, their profit margins are thin. It's very hard for them to find a way to grow. And so many of them have sold out to private equity. And in the past, the study I did from 2017 to 2022, 85% of the mergers and acquisitions were private equity buying out autism service providers. And because they they just wanted to grow, or they've been doing it for a long time, they needed to get out. So part of it has to do with the structure of our economy. A third reason is that and you'll see in the Stewart case, is that the CEO becomes part of the deal, and the CEO makes a lot of money, or the executive team makes a lot of money by collaborating with the private equity buyout. A fourth area, particularly in healthcare, is that a lot of physicians thought, and now they're second guessing it, and you can see this in like health affairs and the debates going back and forth. Physicians felt that they could just really do well by getting rid of all the administrative stuff, the billing and the complicated administration, et cetera, because a lot of that's gotten more burdensome. And so they have sold their practices to private equity, believing that then private equity will take the burden off the top, allowing them to do medical care. The problem that has arisen, not always, because I'm sure there's a lot of variation, but a big complaint is then because the private equity firm is in charge of billing and administration, it can indirectly make decision. It can indirectly influence what the doctors can and can't do. For example, it can understaff, so the doctors just have to have a higher volume of patients. Or it can decide that it wants to buy X kind of equipment, which is cheaper than maybe the kind of equipment or supplies that the doctors feel is really needed. So there end up being indirect ways that private equity ownership, so the laws say that they cannot make medical decisions, but they can run the service and administrative piece. And so they're called service management organizations. So that is, something that a lot of physicians have faced, and they a lot in good conscience thought this was a good solution. And sometimes it's worked out, and many times it hasn't. We can talk about that too. Okay, does that give you a sense of Serby? Okay. Other
Yes,
questions?
thank you.
Yeah, other questions? Okay, let's delve into the cases. Okay, this is my my mental model of how I think about private equity. Private equity turns healthcare from a social good into a financial asset to be bought and sold. And so you think of Lego chips. So here's a hospital before, and here's after. You pull apart the pieces and you monetize them. You figure out which are good to sell because the market is hot for this or that, which are good to keep. Then if I keep these, how do I maybe buy something else and put it together? And it really, I think the Lego analogy is a helpful one for me at least, because it's about reconstructing, reconfiguring healthcare entities according to what you think will be the most profitable for you to extract money. I mean, I'm going to get rid of, I buy a hospital, I'm going to get rid of the maternity ward. That doesn't make as much money. Or I'm going to get rid of these, but I'm going to beef up my trauma center where there's, I get much higher reimbursements. So there's that kind of restructuring that can go on if you start to view a healthcare organization as a financial asset to be maximized, bought and sold and managed. And so it then comes to extract wealth, often primarily through financial strategies rather than operational ones. So the balance, it doesn't mean that there isn't operational, but the balance between thinking about finance and thinking about the healthcare mission gets shifted. And that's what I've seen in the case studies we've done. Okay, so here's Steward Healthcare. How many of you have heard of Steward at all? Oh, good. Oh, one? Okay. Good. Well, here's a story for you. Steward Healthcare, I mentioned, Cerberus Capital bought out the Caritas Christi healthcare system in 2000. They started in 2010, they closed it in 2011. We started studying Steward at that point. We literally have kind of monitored it along the way. The leveraged buyout was about 40% equity, 60% debt. They immediately put in a board of directors, not that we're medical, but they had Ralph De La Torre was the then CEO. He was a very respected surgeon who was trained in engineering at MIT, and then I believe his doctorate in health in medical studies was at Harvard. Very, very renowned. And he became the chair. He decided that that the care system needed private equity infusion, and that was the solution. Remember, it was a time when all of the community hospitals were doing bad because it was after the Great Recession. They were all struggling. And, you know, many of them continued to struggle and then came out of it. Ralph de la Torre decided to partner with private equity. So it was him. There were 5 partners from the Cerberus board, and 1 real estate developer. So we do not have a lot of medical professionals on the board involved in decision making. 2011 through 2015, the Massachusetts AG required certain conditions to switch the nonprofit to a for-profit status. And that's what AGs in all states tend to do. And so Stewart agreed to preserve jobs, not sell or close hospitals, although it did close one, invest in certain facilities, but it did not use its own equity. It simply took out loans and kind of loaded Stewart with some more debt. And then it also sold some medical buildings. And then in 2015, the AG released it from oversight. So that occurred 2016. Immediately, Stewart sold all of the hospital property. By that time, it had like 9 hospitals, sold them all to a real estate investment trust for $1.25 billion. It immediately paid its investors about $500 million and itself. So within 5 years, payoff is done. They've more than doubled their money through that sale leaseback. Now the hospitals settled with long-term leases on property they used to own. The OpCo, I'm going to go into a little more depth of what I talked about, splitting the operating and property model. They split Stewart. The real estate investment trust is a hidden phenomenon. Real estate investment trusts are tax exempt entities that simply they buy real estate and then they do the sale leasebacks, in which they then do a lease back to the entities. There are long-term leases for usually 10 years, and they get a steady stream of profits that go back to their shareholders. And so MPT buys the property once owned by the Stewart hospitals, leases the property back to the Stewart hospitals. And it's what they call a triple net lease, which is incredibly onerous. So Stewart must pay not only rent, but all of the costs of maintenance, repairs, utilities, taxes, insurance, everything. On property, now this property the hospitals had bought in the late 1800s was in prime downtown area. So then Medical Properties Trust calculates the rent at current market value, which is very, very high. And there is an annual escalator of 2 to 3% a year. The hospitals rent revenues immediately start falling, and Medicare and Medicaid can't keep up. So by definition, in 2016, we said, okay, this is not a sustainable business model for the hospitals. So what happens? I want to talk about why they separate this property. Well, that's because the stock market values the property much higher than it does the operations, the healthcare operations. I'm going to give you some examples. And then let me talk about, first of all, the financial logic. So Cerberus can monetize the property and pay itself back. MPT is willing to pay a large upfront sum to the private equity firm because they're going to get this steady cash flow. And then MPT targets hospitals, and they say this in their investor presentations, that are truly needed in the market and that the community would suffer if the hospital closed. So in other words, they target hospitals. They know if something goes wrong, the state or the locality has to find another tenant. And this is, I mean, I think you can find this directly in their statements. So I call this a Ponzi scheme, and I'm going to show you more as we go on. But essentially, well, let me go on with this and show you. Okay, so with the help of MTT, who is doing the debt financing, Steward buys additional 31 hospitals from other private equity firms who want to unload them, who've already put a lot of debt on those hospitals. And this is largely financed by Medical Properties Trust. Then here is an example I particularly want to show you. So first they buy 8 hospitals. CHS is a former private equity owned hospital system. They pay $311.9 million. The property is worth $301. They are valuing the healthcare services, all the good people, the skilled staff, the doctors, the operations at 3% of the value. Same with the 18 hospitals that were in the IASIS system, another private equity owned system. IASIS needed to sell them because they needed to get money back to their investors. Steward was looking to buy them because they were ready to expand. So it's a horse trading essentially of hospitals. And then they sold for $2 billion and 75% is valued in the property. And then same with the 5 more hospitals, 82%. So there's a buying spree of debt-ridden hospitals, all designed to buy and sell, horse trade, with MPT financing it. So Steward expands and then MPT gets the rent back. The idea is Steward had become bigger and bigger, and then maybe they have more bargaining power with insurance companies, with vendors, etc. In 2021, finally Cerberus wants out, so they exit Steward with a total of $800 million that they've made in 10 years. And they sell the hospital system to the physicians led by Ralph De La Torre, financed by MPT. At this point, MPT, they are buying, I think it was like 36 hospitals, valuing them. Now, this doesn't include the property. They're valuing 36 hospital operations for $335 million. About 10 million a piece. That's all they're valuing people like you. These are purely financial plays. And MPT becomes Steward's largest owner, creditor, and landlord. So this is just happening now. And what are the outcomes? Well, Steward was the worst financial performing hospital of any in Massachusetts. It had the highest debt, higher than average patient falls, infections, patient readmissions, vendors were not paid on time, massive understaffing, and doctors' autonomy was curtailed. For example, they were forced to only admit into Steward hospitals, even if they felt their patients needed a specialist in some other hospital. 2020 to 23, so there were several hospitals that started closing throughout the country. A woman in a Massachusetts hospital just in January died giving birth because a vital device had been repossessed by a vendor who had not been paid for months. This is all Steward's cost cutting. A Florida Steward hospital was bat infested because the exterminator was not paid. Conditions at Steward, Louisiana hospital were described as third world medicine. 20 to 2023, Stewart avoided bankruptcy because of the CARES Act. It got bailouts of some, I think 600 million or something like that in grants and loans, and also MPT loans. But Stewart hospitals were not paying rent. And finally, Stewart went bankrupt in 2024, just a month ago. It had paid $2 billion in rent and mortgage to MPT, owed 50 million to MPT in back rent and millions more in future years, owed 600 million to unsecured creditors, which means the creditors who are unlikely to get paid, and faced over 24 vendor lawsuits for unpaid bills. MPT future is questionable. It had invested 4.5 billion in Stewart. Stewart properties were about 25% of its portfolio, so very concerning. MPT stock fell from $24 in 2022 to $4 in 2024. So the takeaway is here you have three entities, MPT, Cerberus, Stewart, with mutual dependence. Cerberus extracts 800 million, MPT 2 billion in rents. The CEO extracted millions in personal wealth, and none could have done it alone. It was a Ponzi scheme. For other stakeholders, the staff now are desperate. If you hear about interviews, they have a very uncertain future. And then the taxpayers are subsidizing billions in wealth to private equity, because Medicare and Medicaid is funding all 60% of the hospitals, and to the tax exempt REITs. And almost all these actions were legal. So this is the most extreme case that we have. I am looking at our time, which I'm supposed to end at 3, so I'm on too long. And this is just you can read these slides. There have been massive legislative hearings, Senate hearings. Senator Warren just put in I'm going to skip this case, which is about Envision and doctors, because we don't have much time. You can read it, or I can tell you later. And this is just private equity ownership of hospitals in the US right now, which is quite extensive. 30% of all proprietary for-profits. This is total private equity investment in healthcare, just to give you a sense of how it is exploded. You see that it was kind of flat, except for the bubble year here. It was kind of flat in here, but from about 2012-13, it escalated. This is an outlier. This was a pandemic year, and it's come back down, but there's been an escalation that will continue. And then finally, this gets back to my point. Private equity turns healthcare into a financial asset. It extracts wealth for outsized returns in a short time period, because that's what it's promised its investors, uses a range of financial strategies, targets hospitals, nursing homes, all sorts of different segments. The new hot markets are mental health, hospice, and there are macro effects that I haven't had time to go into, but there's a fragmentation of local systems and local control, because if you have these large corporate entities that become national orientation, then the doctors and the healthcare professionals and staff are working for a national corporation that is maximizing its interests at the level of the national corporation, not necessarily in your local healthcare system. And finally, I'll just put up this slide. This is, Senator Warren and Markey introduced a law just 2 weeks ago called the Corporate Crimes Against Healthcare Act. It is specifically focused or in response to Stewart Healthcare And you can read it, creates a new criminal penalty for up to 6 years in prison, provides state AGs and the DOJ with power to claw back compensation, civil penalties, provides, prohibits federal funding to entities that sell assets. So trying to go after these asset sales, repeals a tax rule that allows taxable REITs to exert influence in operations, requires healthcare providers to receive federal funding to publicly report. So it goes into transparency and accountability, and mandates HHS to report to Congress on harms.